boardroom to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
All right. Welcome, 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 everyone. This is episode 250. Can you believe the same number of how old America is? Of the Crisis Jam, I am Laura Evans. And for this week's feature presentation, we have Dr. Tom Insel. When the crisis ends, then what? So gear up, strap in. Let's get started on this jam. As a reminder, you can always go to crisisjam.com where you will see all the things that you need related to the Crisis Jam, including information on Crisis Now 4, how to register, watch the live stream. Hey, everybody joining us on the live stream, sign up for the newsletter, watch old vintage episodes. I think it goes all the way back, David said, to episode 35. So from episode 35 to episode 250, you can watch them on YouTube, broken out by segment, highlighted here, color-coded, in case you want to watch a fireside chat, a debate, a live on location, a day in the life. Whatever you're looking for, there's a good chance that we have it. And if we don't, then reach out so we can get you as a featured presenter. Just make sure you like and subscribe so you don't ever miss one. And so for today's hot seat, we've got the audience. That's right. You all are going to be answering this Crisis Jam hot seat question. I'm not sure if if everyone gets a shirt, but maybe we can do something special for you. As I mentioned, this is episode 250, which is also how old America will be this year. So for episode 250, we had to put it on the Washington Monument. That's right. And that is a real picture of 250 actually projected. So was it for the Crisis Jam? Who's to say it wasn't? And fun fact for all you Washingtonians, maybe you all already know this, the Washington Monument is legally required to be the tallest building in DC. So maybe put that in the chat if you know how tall it is. We can see if we can get any swag for you. So the Crisis Jam across 250 episodes have actually had 258 featured presenters. So more featured presenters than we've had episodes, which is amazing. We've had 212 people present one time. For two timers, there were 26. For three timers, trifecta, we had 13 individuals. And then for our four timers club, 7 people have presented. Oh, good job, Kristen. Great answer there. 7 people have been have done a featured presentation. And so we are very honored to induct them into a feature 4 timers club. If you're on our backstage pass, you know a little bit about that. But here's the question. All of these speakers have given featured presentations 3 times since 2020. Who has joined the 4 timers club? All right. We've got Margie Balfour, Matthew Goldman, Richard McKeon, and Hannah Wesolowski. And so while you're thinking of this and weighing in on the poll, more fun facts for you. So the Crisis Jam, as we know it, officially started in September 2020, but the conversations started all the way back in March, just as an informal working group to help get the Designation Act passed, to talk about crisis services, and then kind of formalized with an agenda in September. So since September 2020, which of these people have been 4-time featured presenters? Let's see. Jen, that's such a great idea. A special jacket for 5 times hosting. Jen, I would love to see what you get, what you think should be the special jacket for the Four Timers Club. Do we have those poll results? Let's see. Okay. All right. So, our audience today, you all think that Richard McKeon has been a featured presenter 4 times, 45% of you. 31% of you think Matthew Goldman, 19% Margie Balfour, and 5% Hannah Wazalowski. I'm going to turn it over to David Covington to give us the real answer.
Thank you so much, Laura. Now, Richard McKeon has had the most appearances on Crisis Jam by a country mile, but we're talking about the new Four Timers Club, and I'm here today to induct Dr. Matthew Goldman into the first person to join the Four Timers Club. Hannah, Margie, Richard have all done featured presentations 3 times, but Matthew, welcome. Thanks for joining us again this week.
It's great to be here, and thank you for this honor. And now I really want that 5th time so I can get a jacket. I'm going to hold you to that.
So, we're going to call our jacket club the Four Timers. So if there's a jacket coming, you're already getting it. Now we're going to solicit our audience a bit, but let's go back memory lane a moment. Matthew, you were first on in episode 8, pitching the idea of a National Crisis Research Consortium. I believe you were a fellow in Anita Everett's office at the time at SAMHSA, but already thinking of Maddie Gould's work in 988 and beginning to focus on that broader continuum. You came back in early 2021. You were talking about data in San Francisco and Georgia. In particular, you had done this Arizona Medicaid analysis, which was just terrific, looking at escalation in crisis services data. And then you were again on in 2022, so 3 years in a row. Then you were with San Francisco. I believe it was ACT and homelessness services and other crisis care that you were leading. And then, Matthew, you and your wife, I think you had a brief interruption with a couple of kids and took a few years off before joining us again last week to join the Four Timers Club, talking about the King County system. So that 6 years went by fast, Matthew.
No kidding. Yes, and it's been a pleasure following Crisis Jam along the way. The way this group has grown and the way that this group is such a basis for advocacy, like the people who join this call routinely are so active and engaged. It is really awesome to have been a part of it for so long. So thank you
in addition to those 4 times being a featured presenter, Matthew, 3 roundtables, 6 data corners, 2 trivia, a breaking news, and a quote of the week for 17 appearances in all. So please, to the community, please welcome Dr. Matthew Goldman, our inaugural Four Timers Club inductee. Thanks for joining us, Matthew.
Appreciate it.
Hey, so Matthew, at minimum, this badge is coming. We're working on a Trusted Voices badge that we'll give to our Four Timers. But Laura, what else should we do?
I like the idea of a hoodie or a scarf. I mean, Matthew, do you have ideas? You're the newest member of the club.
Any of the above. What, I know you've got the merch store up and running, so.
That's right. Well, and you can also go to crisisjam.com and check out the merch store as well. So keep your ideas flowing in the chat. You'll see here, we've updated for folks who are in our backstage pass. They saw the sneak peek. We've updated the celebrities to include you, Dr. Goldman. So make sure you get a screenshot of this. Yes. Oh, thank you, Dr. Goldman. And as you mentioned, this has been such a community for advocates. And I think that's a perfect segue into bringing in Hannah Wazalowski with our breaking news.
Hey, everyone. Good to see you. It's been a little bit. I look forward to coming back for another feature presentation sometime soon. I did not know I had done three presentations. So love this group and love the collaboration here. We just wanted to share, we actually did some polling both in July of last year and then again in November/December. We released it in early December. And we just wanted to share some data. As you know, hopefully NAMI has been conducting polling on public awareness and sentiment around 988 and crisis services since before 988 even became available nationwide. We started just before that in late 2021. So we've been tracking awareness, and we found some really interesting data in our most recent poll. First of all, about 73% of Americans have at least heard of 988. That doesn't mean they know what it is, but they've at least heard of it. And about a quarter of Americans are somewhat or very familiar with 988. So that's incredible progress, more than double from the first post 988 tracking poll back in 2022. Awareness is particularly high among people who are age 18 to 29, who have a college degree, and who have higher incomes above 100,000. So clearly we have work to do to reach a broader audience, and NAMI is proud to be part of the community that's spreading the word. People are still very committed to building out a crisis continuum of care. This is a survey of a demographically representative population across the country, 2,000 adults. And people support funding for crisis services both at the federal level and the state level. Almost 9 in 10 Americans say there should be federal and state funding for 988 and crisis services. Nearly 2 in 3 Americans support funding for LGBTQ plus youth specialized services. So, you know, as we continue to work toward that, it's great to see so much support for that specific service. And 85% of Americans believe people should receive a mental health response, not a police response when they're in crisis. There's a lot of other data in there. We asked about support for physical barriers for suicide prevention on bridges. We asked about federal funding. We'll drop the link in the chat, but we wanted to make sure you all knew that this data was out there and to leverage it in any way that you can to advance crisis systems in your community. And we're always open to ideas and questions that you might want us to ask in the future. So definitely be in touch if you have thoughts on that, so we can continue to explore what Americans think and what they support.
Perfect. Well, thank you so much for that, Hannah. And thank you and NAMI, not only for tracking this information, but also for the great work that you all did last week in helping to mobilize the mental health community when news broke of programs for substance use, mental health being at risk for their funding. You all activated, and your members activated, and you all in this 988 Crisis Jam community activated, and so that funding has been restored. So thank you for that. Okay, so we're going to move forward.
Has come for this. Nom, nom, nom.
Cookie Monster says it's time for over under. So we're going to bring in Daniel Heron from Vibrant Emotional Health, as well as Samira Schroeder from NAMI. And Samira, I apologize if I did not get your last name correct. So for over under, for folks who are first time joining us, one person, Daniel, will guess the answer to this question, and then Samira will say if the correct answer is over or under Daniel's guess. So sticking with that same theme of making sure that folks are aware of 988, Daniel, Vibrant and SAMHSA, in addition to Vibrant and SAMHSA projections, the Crisis Jam anticipated the full universe of potential 988 call volume. So once folks were aware of 988, how many people would call in annually? So
annually. Oh, that's a great question. And this is going back to when those projections were made. Oh, I remember it being really high, the Crisis Jam projections, I think. So I'm just gonna guess 50 million and see. That may be high, that may be low, but let's see what Samira thinks.
okay, 50 million. Samira, higher or lower, over or under?
I'm gonna say under.
Under. Okay, let's see what folks in the chat. Do you all think that there's a bit of math here, and we'll go quickly. When we think about just the lifeline calls, we were thinking 2.5 to 3 million in that universe. There's about 13 to 15 million behavioral health calls on state, county, local lines that could be folded into 988. Then if we take 10% of all the calls that go to 911, that's about 24 million for a total of 40 million. Samira, you're correct. It is under, but Daniel, you were so close. All right. Thank you. Thank
Thanks,
you,
Laura.
Renee, for your under. Okay, so now it is time for our featured presentation. This will be a fireside chat, and I'm going to turn it over to our moderator, David Covington.
Tom, thanks so much for joining us again. It's been a few years. You were, of course, a key architect of one of our last big milestone episodes when we had Dr. Berwick on the 100th Crisis Jam. But welcome to episode 250.
Wow, congratulations, David. I think I have been with you on almost this entire journey. So it's exciting to think about hitting this milestone. It's amazing, actually, as other people have said, what you've been able to accomplish here in the community that you've created is really wonderful to see.
You've been such a friend, innovator, mentor, support to so many of us in catalyzing our work and guiding us and directing us. It's been a decade, Tom, since you left NIH?
Almost exactly. I left end of 2015, so I served all the way through the Obama and before that, the Bush administration. So from 2002 to 2015, Richard McKeon was at SAMHSA throughout that time and got to know Charlie Curry and Pam Hyde and names that'll be familiar to lots of people on this call from SAMHSA during those years.
And when you mentioned multiple SAMHSA administrators, you were one of the longest serving NIH directors in the Institute's history. And during that time, so much work of bringing science and data, but this idea of, and a little bit controversial at the time, of you pointing out the gap between scientific discovery and research and the real world outcomes in the mental health, substance use, suicide field. And we're going to jump into that today, Tom, as we talk about what happens after a crisis. So, Tom, what does that week look like, that 30 days look like, but in particular, that first week after a person has had a crisis engagement? What's the real world of that? And then what should it look like, Tom?
Yeah, so a lot of my reference point on this comes from my own journey of being deep in the science and thinking about how do we get a more detailed understanding of the cause and the mechanisms of mental illness. I was giving a talk now about 11 years ago to a NAMI group in Oregon and describing some of the advances of the Brain Initiative that Obama had led and a bunch of the things we were doing through the NIMH and through other NIH institutes that were really spectacular science. And somebody got up afterwards and said, our house is on fire and you're talking about the chemistry of the paint. Yeah. And he went on to describe what his son had been through in terms of numerous crisis events and just the absence of a system of care to help somebody with SMI in a world in which we know actually what works and we know what to do. Yeah. And so what really activated me at that time and led to a book that I wrote called Healing was to try to understand how is it that when we, thank you, David, 10%, if that's your commission. So how do we get from a world where we know what to do and yet don't deliver to a world in which people actually get access and get high quality services in the way that we can see population health changes? And that in a way is to your question about what does that first week, first month look like? It's a sort of service cliff. The hope was that we would see crisis as the front door to a care system that was comprehensive and focused on recovery. And we have now built a pretty good front door, but what we don't have is the whole house behind it to actually ensure that people recover. And that's become the work of the last decade for me.
Yeah. So, Tom, after that, if crisis is that front door, where are we losing people afterward? Is it clinically? Is it socially? Is it relationally? What is that cliff look like exactly?
Yeah, it's all of that and much more. I had a great experience just before the pandemic. I had our very new governor in California, Gavin Newsom, had asked me to become his mental health czar. I'm not even sure still what that means, but for a year I spent really driving the back roads of California, trying to understand just that questions like, where are we missing this? At least in California. And California is an interesting place because our budget here for mental health services so far exceeds any other state. It's extraordinary. And yet our results are not any better. In fact, in some cases, they're quite a bit worse. And so he was struggling with this and asked me to try to figure it out. And over the course of 12 months, and meeting with lots and lots of different people in the system, I went in with a bunch of priors. I thought I actually knew why this wasn't working, and I had kind of the usual list of things. It's access, it's stigma, it's not enough funding, it's not enough of a workforce. All of that, I was convinced, was not really the core set of problems. It really came down to a few things. One was there was a problem with capacity. We don't have the beds, we don't have the people, we don't have often what we need when we need it. But the bigger problem that really struck me was something we don't talk about as much, and that was engagement. And that in that period, when after somebody has gotten into a crisis, and of course, in a perfect system, that should never happen. Crisis is actually the symptom of a system failure here, right? But when it does, and it's inevitable that it will, can we create the kind of safety net and the kind of pathways that actually ensure that somebody doesn't have a second crisis, doesn't actually end up in this loop that we see so often. And so this engagement issue is really, I think, the critical one that we haven't thought about enough. Why people don't engage, lots of answers to that. The one that I had originally was stigma. I later figured out I don't think that's really the issue nearly as much as they don't buy what we sell, that we don't have a system that works for people in the way that they want it. And I've really become impressed by this issue around ChatGPT and the fact that 200 million people have chosen to get psychological support and psychological guidance, whatever that is. And maybe it's even therapy from a bot, because they find that is better than what they're getting in the real world of mental health care. And I think that's an indictment of who we are, what we do. And it's one of the things I discovered then back in 2019 is that, well, we have plenty of services, as the National Comorbidity Survey said back in, 15 years earlier, only about 40% of people who could and should be in care are even engaged. That's very different than oncology, cardiology, pulmonary medicine, where the numbers are like 70 to 80%. And some of the people who need the care the most are the least to engage in care. And that really explains a lot of where this system has failed, that we just we haven't solved the engagement problem in a way that works. And in the places where it has been solved, you can see immediately the effects of the care works, but it has to be a kind of care that people will actually engage in and be able to benefit from.
So you're sort of leading into this throughout with this focus on engagement, Tom. So you're saying this isn't a failure of services so much as a failure of connection? Is that
Yeah, I
right?
think it is. But it's because often the services we have aren't the services people want to connect to. And I think part of this comes from, and this is what my book was about, from a model that we borrowed so much from healthcare, which is very much a successful model for infectious disease and an unsuccessful model for behavioral health. that it's a model that has an expert physician who has an answer that you get a diagnosis, you get a medication, and you're on the path for getting what you need. That's a lovely and a wonderful model. It just doesn't work in behavioral health, and the model that we need is one that I've called, it's not the best word, but a recovery model that really focuses on the 3 Ps: people, place, and purpose. And that's what the book is about, is how do you actually create a system that's focused on those 3 Ps: community, creating a space for people to recover that's safe, and also having a purpose, whether that's work or service or whatever it happens to be. That's actually what we all need, but for people in crisis, people with behavioral health challenges, that is really the key. And that's not the way our behavioral health system has been built.
I can't remember if the conversation was with you or Denny Morrison, but it may have had a similar conversation with both of you where you were talking about healthcare engaged, and I can't remember if it was a hip replacement or a cardiac care, but the follow-up that was a standard part, it was an amazing level of engagement and outreach and follow-up and support that was just baked into that. What do you see that follow-up care being, that successful engagement? What does it look like, Tom? What should that week look like afterward?
Yeah, I had thought a lot about that, and I thought I knew what that could look like. And then I had a personal experience. I have an adult son who developed COVID just about a year and a half ago. And like all of us, he was sick for about 3 or 4 days and did fine. And then about 6 weeks later was in acute congestive heart failure. And he had developed post-COVID cardiomyopathy, which is actually fairly common in young men, though I didn't know that. He had never been sick, ended up in the coronary care unit, acute congestive heart failure. When he was discharged, he was on 9 medications. He needed to have an EKG every other day. He had 3 different physicians, and he was completely overwhelmed. Had no idea how he was going to manage this. I went to pick him up to take him to an appointment, and I was asking him about how he was going to deal with all this. He said, "Oh, not a problem. Kaiser has given me an advocate." I said, "What the hell is that? I've never heard of that." He said, "Yeah, no, I have a single person who I work with who coordinates all this. So she makes sure that the pharmacy contacts her right. She's got all my appointments. I just deal with her, and she manages the whole thing. And it's actually pretty effective. And he's done great. It's actually worked out really well." I began asking myself, why don't we have an advocate in behavioral health after a crisis? Why isn't there a person there who can navigate to care, coordinate care, and then manage your care throughout and create a kind of system? And that was actually the origin for Benchmark Health, the most recent startup that I've done with David Moe, who you'll meet in a moment. And the idea there was for anybody in crisis, for anybody who needs behavioral health care, it's an impossible world to navigate. But why not have an expert? Why not have someone there on your team who has your back, who knows you well, and who can give you what you need in a way that's coordinated, and most of all, stays with you through the journey to make sure the outcomes are the outcomes that you wanted. So you start by saying, what's the goal here? And you finish maybe in 2 months or 6 months, or maybe a year, or maybe longer, having achieved those particular goals. And there's someone there who is accountable for that. And that's actually, I think, the model that we need to think about. I'm not sure that we've perfected it, but that's what we're trying to do at Benchmark.
A peer navigator, Tom.
It is more than a navigation, David. It's actually, because I think it is important to have somebody who knows what's available.
Yeah.
And when I say available, I don't just mean clinically, but I mean all of the social services. I mean what's available online.
Yeah.
What are the telehealth companies? Which ones you can trust? Which ones you can't? And maybe even the AI tools and all of those things that people are going to naturally. Why not have somebody in the loop who's there to say, I want to make sure if you're using this, you're using it in a way that's effective. But most of all, and this is really the key, because it's where this field, I think, has really failed, somebody who's accountable, somebody who's making sure that we measure outcomes and that you actually get the outcomes that you wanted. in the way that you would for an infectious disease or cardiovascular care.
So, Tom, I used the word navigator. Somebody in the chat is talking about targeted case management, and I was looking for what that difference is, and you used the word accountability. It reminds me, my business partner and one of my closest friends, a real innovator in the space, Greg Graham. His had two sons who struggled with both mental health and very serious substance use, were involved with the criminal justice as well as the mental health system, and just saw this lack of follow-up continuously, the obstacles, the challenges. And the concept he came up with, he called it an honest broker, but he always described it as, in that crisis, someone has to take you by the hand and hold your hand all the way through until you're either on that journey on your own, or the next person has taken your hand to carry on that relationship, because people get left in this silence. They get left. So, Tom, that you mentioned accountability. Let's push on that for a moment. Where does that, how do we structure that accountability in the system? Who is accountable, Tom, for that follow-up?
Yeah, it's a great question, David. And it is a who question. It's not just a what and a when and a where and a how question. It is very much who. And if you look at the current system, I don't think anybody is accountable. Sometimes a family member who's accountable. But this is where I think one of the places, when I made my own list after a year of surveying the services in California, it was really not just engagement, but it was quality and accountability that really kind of topped that list to say, how do we build a system that actually does this? Now, in our case, I think part of what has been a problem is there's been no consensus about what is quality and what are we actually measuring that matters? Is it a PHQ-9 and a GAD-7? Is it a particular goal attainment? Is it some kind of research outcome like a Hamilton depression score? Or is it those three Ps? Is it social support, people, place, and purpose? Is that what we really want to go after? And I think for me, the critical piece of this is establishing what we mean by success, establishing what we are trying to accomplish, then creating the individual, like in our case, it's our advocate who is accountable for delivering on that, whether that requires inpatient care, maybe it requires long-term psychotherapy, maybe it requires medication, but most of all, it requires the coordination of all of the tools that we have to make sure, just like you would in any other part of medicine, somebody's getting the very best outcome, defining what that outcome is, and then measuring against that. And then, I think the critical thing for us is not, I talk a lot about the three Ps, but it's the fourth P. It's figuring out a payment system that rewards actually outcomes and not just time spent, or a kind of fee-for-service world in which you get paid if somebody shows up without really any accountability about what happens in that session. So is somebody getting better or not? And of course, in Medicare Advantage and elsewhere in healthcare, we have worked a lot around value-based care payments and trying to figure out how to make that work. It's hard to do in behavioral health unless you've got some consensus about what is value, what is the outcome that we all care about. And it's really hard to do if you're in a carved out system where you can't see the total cost of care savings.
So we've got to get to the point that someone's coming alongside and supporting you through that process, just like your son. So, Tom, when you wrote Healing, and of course it's been almost 4 years ago now,
right?
You pointed to things you saw as promising. Well, let's come to 2026. What gives you the most hope, Tom, that this alongside support, that advocate, that broker for the person is where do you see that moving in the best way?
So I think it's a work in progress. There are a couple of things that make me hopeful, and one of them is actually realizing that we have good stuff. It's easy to forget that because the outcomes are at a population level are not great. But knowing that we have good treatments really does matter. Knowing that we have clubhouses that are really effective for recovery. We have a whole range of services that we know work. And so really it's a question now of aligning our payments and aligning our system of care towards not the high acuity, high expense kinds of interventions, which we have now, but things that may be actually less expensive and are far more effective in the long run. And so what I've put all my time and energy into is actually creating the kinds of companies, because I think a lot of this has to happen in the private sector,
Right.
that will demonstrate the business case for recovery care, demonstrate that you actually will save money as a, in a $5 trillion healthcare system. You can save money by providing the kind of care that helps people get the 3 Ps and keeps them out of the emergency room, keeps them out of inpatient units, which are the most expensive, most intensive, and probably in some ways least effective in the long term when you look at actual recovery as an outcome.
Tom, thank you so much for being here. Thank you for your leadership. When we started 988, all of us together, oh gosh, going back to 2022, the conversation was generally someone to call, someone to come, and a safe place for help.
Right.
And increasingly, you see everybody moving to, and someone to walk alongside, to follow up. So your impact on that. Thank you so much for being here. And Laura, let's get David and Hannah's perspective on Tom's direction.
Yeah, thank you, Tom. That was great. And thank you, David, for moderating that conversation. So we are going to move to our roundtable. And so I'm going to bring back Hannah Wesolowski, who is the Chief Advocacy Officer for NAMI, as well as in our roundtable, we will also have, I will just give it just a second. Daniel Moe and David, apologies if I've butchered your last name, who is the founder and executive officer of Benchmark Health. So David and Hannah, David, I'm going to start with you for your reflections and then move to Hannah.
Well, thank you, Laura. Thank you, David, for having me. And it's funny, you call me Daniel. That's my identical twins' name. So there's something
I can feel the
interesting
vibe
going on here. As a brief back, I'm a psychiatrist by training, and did my postdoc with Matt Nock, and very interested in how we can predict and then prevent suicidal thoughts and behaviors using digital biomarkers. So for my postdoc work, we put fancy Fitbits on people. We measured how much they're sweating, how much they're shaking, and then try to predict when someone's suicidality skyrockets and then intervene ahead of time. And these are high-risk patients on the inpatient unit at Mass General Hospital. So very interested, in short, in bringing data to bear to triage people to the right level of care. I was hearing what and Tom is my co-founder on this Benchmark Health effort, and I was hearing what David, you were saying about being an honest broker, finding an honest broker, and what Tom was talking about in terms of accountability, and that's the key here, right? So Tom and I are both psychiatrists. And very often, family members or friends of friends would ask us, "Hey, I need a therapist. I need a psychiatrist in this specific state." What do we do when we're treating our family members and friends? We will look at the zip code. We'll call our friend from residency. We'll call the director of programs, find care, and say, "Hey, look, I know your wait list is very long, but do me a solid, and I'll help you out the next time you're in Boston or you're in San Francisco if you have a patient there." We make sure they schedule that appointment, and then we close the loop. Did you go? How was it? What was that like? Are you better? If you're not better, I'll re-triage you. So that's the commitment that we have, right? The incentives there are to get that person to go. That's the real accountability that we need. So the idea here is that how can we reproduce that for people who may not have a psychiatrist as a friend and scale that up? And that's the idea here. One other point here I'll just mention is the tailoring is very, very specific. So I likened our field of psychiatry, and as a psychiatrist, I feel like I could be direct about this. We are where cancer was 60 years ago. So 60 years ago, when you had cancer, it was radiation or it was chemo. There wasn't all these subtypes of cancer, and then you get these very specific doses of radiation plus chemo or genetic medications or whatnot. It was very blunt. And the idea here, when someone presents with depression, there are 20 different types of depression. And the approach could go from peer support to therapy plus medications to IOP partial to emergency room immediately. That level of tailoring today, we don't really have unless you're going specifically to a mental health professional. And how can we get to that tailoring? The only way we can do that is do what the oncologists, what the cancer experts did. They actually looked at outcomes and said, okay, now we have a thing called non-small cell carcinoma. Why does that matter? Because that responds to a specific type of treatment. So what does specifically respond to peer support, which is free, or therapy, or psychiatry, and we figure we have to look at the data, and it's not about tribalism of meds versus therapy versus group therapy versus peer support. It's about what works. And then we begin to send people to places where it works. So that's the principle of this universal triage idea, and where there's no incentives. I saw a very helpful comment in there that said, will these navigators, will these advocates ever refer out of network? It's a great question, because if the insurance company or the providers are providing these navigators, no, they're not going to refer out of network, but we will. The categorical fiduciary is to the patient. There is nothing that's out of network, and that could be a free service. And I can tell you, as a Mass General person, for the longest time, we did not refer out of the Mass General system, regardless of what happens, because that's losing a patient. For payers, you never refer out of network because that's dollars out of the system, a lost member, right? A disengaged member. So how do we start from first principles and really serve the patient at all times and serve as their clinical fiduciary? That's really critical. And it's one of the reasons that Tom and I established this as a public benefit corporation, where that's within our mandate, within the company's mandate, that we have to optimize for the patient, not for any third party that may be about. So thank you for having me, David.
Oop, Laura, you're muted.
No, that's fine. I was just going to kick it right over to you, Hannah.
Yeah, I so appreciated this conversation. And, I think what we always see in the mental health space is that traditionally we don't ask people with mental illness what their experience was like, or if they are getting what they need out of something, out of treatment. And, what Dr. Insel said about purpose really hit me, because that, for coordinated specialty care, that's a key tenet of why that's so successful, because we focus on what people want to accomplish, what they need, and how do we help them achieve it. It's the accountability gap is pretty significant, and we have a lot of catching up to do in the mental health space. And we're hearing from at NAMI, we hear from families and individuals every day who aren't able to access what they need, who can't find treatment that is tailored to them and to their unique experience. And we need more conversations and actions like this that really help just get down to how we meet people where they are and we meet their needs. For other types of conditions, we focus on what the individual is willing to do, what they want to do, what their goals are, and their treatment is tailored to that. And it's really time that we catch up to that in the mental health space. So I know that we're probably getting tight on time, so I won't go on. I just want to thank both of you for your comments and the work that you're doing, and really centering people with mental health conditions in the conversation and in their treatment. That's what we need to see more of.
Yeah. Thank you for that wonderful roundtable, and thank you, David and Tom, for that. Great. I took lots of notes, but we are going to turn it over to Richard McKeon. Richard, are you with us? Okay.
Yes, I am. Just had to unmute myself. Thank you so much, Laura. So I will try to be quick in the interest of time, but I wanted to make sure I announced this last week, but SAMHSA has released its notice of funding opportunity for the 988 Lifeline Network Administrator. This cooperative agreement is for $231 million annually. It's a 5-year grant. So if you do the arithmetic, and presuming that money is available annually from Congress, you're talking about a grant that's of over $1 billion in this work and in the evolution of 988 and the Lifeline. The due date for that is February 27th. We are certainly hoping to get strong applications as part of this independent review process. Also, I would mention that on our SAMHSA's forecast, you can also look forward to release of our 988 state and territorial grants, our 988 tribal grants, and our crisis center follow-up grants. And just a word about the crisis center follow-up. It was great to hear Dr. Insel talking about the critical importance of follow-up in our systems and how that really is a major next step to build on what's been done. These grants originated because we learned in some of the first evaluations that suicidal people who were calling the national hotline at that time, only a portion of them were getting care. But it's not only getting care, it's having someone to connect to during that really vulnerable period. So heartened to hear about some of the incredible work being done in this space. So I will stop there.
Awesome. Thank you, Richard. And thank you for all of the information you provide every week. So appreciate your great work. Now we're going to move forward and we are going to go to our NASHBID update. And from NASHBID, we have Dr. Alan Tien. And Dr. Tien, I'll turn it over to you.
Thank you so much. I really want to thank Brian Hepburn for connecting me to Crisis Jam. Briefly, my background. Is there a slide? I think I gave you some slides, right? Yeah. So my background is psychiatry, and was a professor at Hopkins for 10 years in the Department of Mental Hygiene, now mental health, focused on prevention services and epidemiology research. And after 10 years, I got kind of like aware that all this knowledge that we're developing as university scientists is not being applied in non-academic community settings. And I thought, okay, that's what I want to do. I want to build software that will enable that to happen. That was in 1997. Thought it would take 5 years. Now it's 28 years later. But we are actually doing this. Just conflict of interest. I am the president of Medical Decision Logic. We have a product, BHWorks. It's used in 40 states now. But this example of Staten Island, I think, is really incredible. I was part of it, but really the leaders, they're listed up on the upper left. Ginny Mantello and Adrian Abadi really were two key people. And it addressed over 18 months the issue of community engagement with all different kind of categories of participants. And how do we integrate data into all these processes? How do we use data for accountability? And a major part, and then they use that as a basis to get some Garrett Lee Smith funding from SAMHSA, led by Jay Carruthers, who's the New York State Suicide Prevention Center Director in Albany. And so this is now in the second year. It's comprehensive ecosystem, coordination, connection, closed loop referral for kids identified as having suicidal ideation, high schools, ED diversion, which has major cost savings as well as harm reductions. So this slide has a lot of information, but hopefully these slides are shareable. You can look at it, with more time. And I really like to connect people on LinkedIn, so I'm going to put my LinkedIn profile in the chat. And if you're interested, please send me a connect invite. Next slide, please. So Ginny Mantello is, I call her a category 5 force of nature. She brought all the people together on Staten Island Adrian Abadi is the executive director of the Partnership for Community Wellness, another outstanding leader in Staten Island, and they're both what they've developed, I think, can be scaled across other regions. The blueprint process was 18 months. And as I said, they got funding from SAMHSA and also support from Bloomberg Philanthropy, who is interested to consider how this might be something they support at a bigger scale. VHWorks gives new capabilities to all the participants. We talk about data and workflow and making it reliable and efficient, but people end up reinventing the wheel. But we've been doing this software development for 20 years, so it's actually pretty uniquely capable. As I said, the focus on this project is K-12 suicidality crisis response, closed loop referral with standard workflows, connecting multiple different entities downstream, public school system, 988 mobile crisis, and providers. And one of the constraints has been getting approval from the New York City Public Schools security process. That's been I think 18 months now, almost done with that, we believe. But we bypassed all that with a charter school. It went into action very quickly in a couple of months and already, screened kids, parent-reported screening and identified issues, and are now using that to guide intervention with the community behavioral health providers. Next slide. Oh, so we're expecting all these results. I think everyone's aware of these things. We calculated the Children's Hospital of Atlanta estimates every ED visit for a youth with suicidal ideation costs $5,200. So for every 100 kids that are identified, if we can divert 90% away to outpatient CAMS treatment, then we're saving the payers $250,000. And it's clear, a paper just got released actually by the CAMS folks on the harms of hospitalization and ED visits. Another result of this is going to be high quality population data, numerical data, that supports more evidence being generated to guide, further improvements in policy and practices. Community coordination is increasing, and also with that, everyone's learning more together. Prevention is a huge part of what we think is relevant to crisis response. Let's prevent the crisis earlier. Some of you maybe don't know MTSS acronym. It's an education space acronym, stands for multi-tier system of supports. Tier 1 is universal prevention, curriculum choices starting in kindergarten for kids. Tier 2 is in-school treatment for groups of kids with an issue such as anxiety or stress. And Tier 3 is referral to individual services. More and more that's in-school clinics, but generally it's still mostly referral to outside community providers. So that's really, you need the closed loop referral to make sure that happens and find out what the results are. This whole package of what has been done in Staten Island, to me, is a scalable package which covers everything that is needed that, Tom talked about earlier and others. Everyone knows these things. We've been talking about it for a long time. There's lots of great examples of individual progress, like David's benchmark work, but we want to bring it all together into one ecosystem. This is my graphic to try to represent that. Then I came up with this model of a cell with receptors. So the inside structures are this kind of data and process platform, and we come up with ideas. We test the ideas, get data, generate new knowledge, and that generates new ideas and priorities. But really the participants into the broader world are super important. And some of the categories are researchers, students and families, school personnel, service providers, and administrators and policymakers. Probably another group that would be the financial sector. And I'm going to add one more thing into the chat, which is what I think is one of the best papers I've read in a long time. I'm just trying to collect it right now. Sorry about that. Here we go.
Well, no problem. Take your time, Dr. Tien. Go ahead and put that in the chat. And for folks, we will have these slides available on crisisjam.com. Now we're going to turn it over to Daniel Heron from Vibrant and Samira Strider
I just have
from
10 seconds on this paper. It's called Measuring Regenerative Economics. It combines general system science, network science, and thermodynamics to come up with 10 measurable principles for understanding ecosystems. It's really got some great concepts and vocabulary in it that I recommend to everybody. Thank you.
Awesome. Thank you. We'll take a look in there. Daniel, Samira, over to you all.
Great, thank you, Laura, and we'll keep this brief. I just wanted to highlight a couple of quick state updates now that most states have begun their legislative sessions for the new year. First, want to highlight Missouri. Missouri has 2 bills right now. Both of them would propose a 988 telecom fee at 65 cents a month. That's both for wireless and for prepaid devices. Both of those versions have been filed, but not yet sent to a committee. The good news is the House version has a Republican sponsor and the Senate version has Democratic sponsor. So hopeful that those will move. We also have 2 bills, one in Nebraska and one in Oklahoma. Both of those would create 988 trust funds, which is sort of that first step towards securing sustainable funding for 988 centers. I believe it's the Nebraska one also includes a $3.48 million appropriation to fund the trust fund right away. I'm not sure that the Oklahoma does, however. With that, I'll turn it over to Samira for some more updates.
Yes, I have Indiana. They introduced SB 222. This adds 988 Crisis Response Center and mobile crisis teams as first responders and provides civil liability protections for first responders. And then South Carolina introduced H 4954, which requests that the Department of Transportation place 988 signage on each of the state highway overpasses. Like Daniel said, a lot of sessions are just getting started, so we really hope to see more 988 legislation. Thanks.
Awesome. Thank you so much, Daniel and Samira, for watching that for us. And again, if you want bill numbers, it is linked in the chat. I'm going to turn it over to Kristen Ellis to take us home and introduce our hosts for 2026.
Thanks, Laura, our hostess with the mostest. Like she said, we have this incredible hosting cast, if you will, if we're going to stick with the SNL theme from earlier. And we're really excited to have welcomed Heather. She made her inaugural debut last week, I believe. Yep. We'll have Sean Russell, will join us from the UK. And we get to now announce Sophie, who's going to join us later this year to, keep our youth voice fresh and honest, if you will. We don't want to forget about youth. One of her episodes was one of our most popular. And so it's really important that we keep that advocacy going for our youth because they're our future, right? So thank you so much again to Tom Insel for today's conversation on what happens after a crisis, somebody that worked in behavioral health crisis care and facility. We don't often get to see that other side. It's a powerful reminder that stabilization is only the start and recovery depends on what our systems do next. And in honor of the Four Timers Club that we inaugurated with Matt Goldman, we're going to celebrate 4 jammers. If you didn't notice in the chat, they continued to show up and engage week after week. They had major comments today. So congrats to Dominique Marsalek, Janelle Holtquist, Sonia Burns, and Jen Schlett. We appreciate your comments today. Please look out for a crisisjam.shop code in your email from Marie. And especially thank you to our headliner sponsor, AHP, for your ongoing support, your ongoing workforce segments. And if you're interested in sponsoring the jam, we'd love to connect with you. As we've mentioned, Crisis Now 4 is coming this July, filling up quickly. We're really excited to welcome Benchmark Human Services for joining us as a gold sponsor. We have lots of incredible pieces that are going to be happening. We're really excited to welcome Vermont and Wisconsin, who actually just registered this week. So thanks for your support. If you also want to join us, you want to sponsor, you know where to go. Try crisisjam.com. There's a link at the top. Next week, Dr. Catherine Warburton is going to join us with a frontline perspective on homelessness and crisis care. And in 2 weeks, we're going to explore the role of technology in saving lives with Dan Reidenberg. Thanks so much for watching, everyone. 2026 is a great year. Happy 250 episodes. Be sure to tune in, log on, join the movement, and we will see you next week.